Thank you for joining us today. My name is Dr. Shane McGowan. I am an orthopedic spine surgeon here with OrthoVirginia in the Richmond area. Number one, I know how busy everyone's schedule is and how valuable your time is. So I do want to take a second to just say thank you for tuning in and talking to us with us today about this very important topic, which is endoscopic spine surgery, in particular, something called a medial branch transection. We'll get to that topic in a second, but just to give some quick background, what we're talking about here. Traditionally, spine surgery was known as one of the larger, more invasive surgeries that can be performed. However, through the years, we've slowly adapted a more minimally invasive approach, and the most technologically superior and impressive version of this is endoscopic spine surgery. And this is something that is really just starting to become mainstream. It's been around for approximately 20 years, maybe even a little longer than that. But it's been a very slow growth over that time. And I think technology has a lot to do with how long it has taken us to pick up into the mainstream. Over the past few years, there have been leaps and bounds made in the endoscopic spine world. What surgeries are able to be performed with it, how safely they're able to be performed, and vast improvements in the outcome. So what is endoscopic spine surgery? In short, endoscopic spine surgery is using a very small camera in order to be able to perform the types of procedures which used to require large incisions with significant destruction of the soft tissue to improve patients' symptoms. There are multiple reasons that an individual would require spine surgery, including leg pain, known as radiculopathy, from pinched nerves in the back. It could also be from fractures or broken bones, cancers, arthritis, multiple different reasons why surgery might be required. Endoscopic spine surgery is making what used to be a 3 to 6 month recovery, sometimes year-long recovery, and turning it into just a couple of days. As in fact, some of these procedures we're able to go in, do the procedure today, and get you back to work tomorrow. So we could talk all day about endoscopic spine surgery versus open versus micro and all that sort of stuff. We don't really have that time today. What we do have time for today is to pick one or two smaller procedures and focus on that. Today, I want to talk to you about medial branch transections, or MBTs. This is a very, very interesting procedure because it's the first procedure that we have come out with specifically for back pain. Most, if not all, of the previous surgeries that have been implemented for the spine, in general, focus on leg symptoms, leg pain, leg numbness, leg weakness, with the exception of fractures and broken bones in the lower back, mainly being for back pain, but that's more for stability of the spine. So what an MBT does is it focuses on back pain itself. This is very exciting for us. Like I said, it's the first procedure that we've come out with that focuses specifically on that topic. Where does lower back pain come from? Well, there are a multitude of problems that can create lower back pain. Pinched nerves can create lower back pain. Broken bones can create lower back pain. Cancer can create lower back pain. But we're going to focus more on the most common thing that causes back pain, and that's arthritis. 50% of the population by age 50, 80% of the population by age 60 will have some form of arthritis in their neck and lower back. It is the number one reason for missed days of work and the number one reason for ER visits every year. This is a very, very common ailment that we see throughout the population, not just here in America, but worldwide. So, in the past, lower back pain from arthritis has been very difficult to treat. In general, we have used in the past and still use today a multitude of treatment options for this. Typically, those treatment options include physical therapy, oral medication, injections, and in extreme circumstances, what we call radiofrequency ablations or RF ablations. For the majority of people, these treatment algorithms work. About 60 to 70% of people, just by doing some physical therapy and mild medication, the back pain improves, okay? But for a small number of people, all those treatment options that we just listed fail to provide significant long-term relief. So what kind of symptoms are we going to see if, in fact, we do have arthritis in the lower back? Well, in general, we talk about transverse pain going across the entire lower back, starting in the middle, moving out to the side. It can preferentially affect one side or the other, but in general, it goes to both sides. People often complain of stiffness or tightness in the morning that seems to dissipate when they get up and move around. Forward bending activities, the classic example being vacuuming or brushing one's teeth, will exacerbate the pain, as well as heavy lifting activities. Oftentimes, people will complain that if they sit for a long period of time and then try to stand up, their back hurts. In the same aspect, long walks or continued movement without stopping can bring on that same type of pain. What we're not seeing in patients with arthritis in the lower back in general are the shooting, burning pain down the leg, the numbness, the tingling, the weakness. That is more associated with pinched nerves in the lower back. And if that is something that you are having, we should really need to look into that and figure out what's going on, because that can lead to poor longer-term outcomes. So if we do have that lower back pain, and we've had that lower back pain for some time, again, the physical therapy, the oil medication is where we start. Most people get better. If that does not work, then we talk about injections. These particular injections are mainly diagnostic, not treatment-oriented. The injections that we typically use today, although there are multiple options out there, focus on a small nerve called the medial branch nerve. This nerve, which sits right outside, so let's just pause for a second. Let's talk about this. This is a representative of your lumbar spine, okay? Down here, we have the tailbone, also known as the sacrum, okay? Sacrum here. And as we move up, we have L5, L4, L3, L2, L1. These 5 vertebrae and the sacrum constitute the lumbar spine. Each one of these vertebrae are held together by a joint. And if you look right here, you'll see a bone here, a little slit of gap between, and then another bone there. This is the facet joint. Again, this is what connects one level to the next. This is where we get the arthritis, okay? What is arthritis? Arthritis is nothing more than a failure or a degeneration of the joint surface itself. Normally, our joint surfaces are filled with cartilage, allowing smooth gliding of one bone next to the other. For a multitude of reasons, the arthritis can wear out over time. As the arthritis wears out, the bones begin to grind together. This is not just in your back, this is anywhere in your body. As the bones grind, they create swelling in response. The body believes that there's a problem there, and it sends in a number of different factors to try to alleviate the pain. In the back, when it does that, the swelling fills up inside of the joint capsule. That swelling creates pain, and the pain creates muscle spasm. So we will see muscle spasm and that transverse pain from the arthritis in our lower back. So getting back to it now, if the other more conservative treatments fail to provide significant relief, we start to do blocks. Now, there are several different blocks out there. The one we're going to focus on today, though, is the medial branch block. And although I don't have an exact replica of it here, so if we look right here, this is the main nerve coming out. It's called the nerve root right there, that little yellow thing. And that will go down to the body to do its job. It will help with the motor in the leg, meaning making the move, sensation, and pain down the leg, okay? But right here, and it's not here, unfortunately this model doesn't have it, but coming off of the nerve root, there's a small nerve, comes right across here, right in that little gap called the medial branch nerve. And that medial branch does sensation and pain for the joint right there, okay? When we go down and we take a needle and we put the needle in through the back, right into that area there, and we put medicine in there, we're trying to block that sensation. We're trying to block the pain from that nerve. Again, that nerve is telling us what is happening in this joint here. A successful block will lead to several hours, maybe even a day or so, of pain relief, okay? If we're able to get that block to work extremely well, then we know that the arthritis here is in fact the problem. Again, it's a test. Once we achieve the desired result with that test, and we're able to say, yes, this level, in this particular case, the L4-5 facet joint is creating the pain, we're then able to discuss permanent resolution of that problem. So what does permanent resolution look like? This brings us to the medial branch transection. So medial branch transection is a relatively new procedure. And essentially what we're able to do is take a small camera endoscopically and put it in through the skin, down right into that little notch that we were just looking at where the nerve sits. We're able to identify that nerve with direct visualization and essentially cut that nerve and separate it. Once we cut that nerve and separate it, there's no more signal of pain from that facet joint going up to the brain, which means that there's no more pain from the arthritis. There's about a 90, maybe 95% success rate, depending which study you read, on the results of this, and extremely long-term results, potentially permanent back pain relief. We've had some, I should say, let me go back to this for 1 second here. Okay. So I just want to show you again. Right where we put that needle for the medial branch block, we are able to then put the camera right in here and cut that nerve. When we cut that nerve, it stops all sensation and it stops pain from the joint right there. Okay. One of the big questions that we get asked is, well, is this safe? Because the body has pain to warn us that something is wrong. So if we cut this nerve, will we take all the pain away? And if there's pain coming from somewhere else or something else going wrong, are we not going to be able to feel it? And the answer to that is the only thing that this nerve does, the only job that it has, is to provide pain sensation from the arthritis, nothing else. So if you were to break a bone, if you were to get a disc herniation, if you were to, God forbid, have cancer that was causing this kind of pain, or was causing pain in your lower back, you absolutely would be able to feel that. This is a procedure that takes away the daily pain, that annoying arthritic pain when you wake up in the morning or when you're trying to get things done throughout the day. So I think that in general is a quick overview of endoscopic spine surgery and medial branch transections in particular. I welcome any and all questions at this point.
Thank you so much, Dr. McGowan. We will be answering questions submitted earlier and questions submitted live. Not all questions will be able to be answered, but we will be able to get through several. If you're watching live, please feel free to leave your questions in the comments. Our first question is, do the nerves ever grow back after you've cut them?
That's a great question. This leads into something else called an RF ablation, or radiofrequency ablation, which essentially is the same idea. And this is what we had done for years previously, and we still do today with great success. With an RF ablation, what you do is where we put that needle in for the medial branch block, instead of putting the needle down there, we put a small little probe that burns the nerve. When that nerve is burnt, it takes the pain away. However, burnt nerves do grow back. So in general, the ablations last for 6 months to a year. What is different between an ablation and a transection? And with the ablation, as we just said, the nerve is being burnt. With a transection, the nerve is being cut and separated. Nerves can go back, whether they're cut or burned or whatever the case may be, if the gap between the two remaining parts is less than a centimeter. When we do the transection, when we do the medial branch transection, we make sure that we cut the nerve, separate it more than 1 centimeter, so there's no chance of that nerve growing back. In this way, we're able to provide long-term permanent pain relief.
Thank you. What is the recovery like after a medial branch transection? How long are you off work, and do you need to do physical therapy?
Another great question. Everyone's a little different, obviously, when it comes to procedures and recovery, that kind of thing. But in general, We tell people 2 or 3 days and you're pretty much back to normal. Again, these are very, very, very small incisions that we're making, sub 1 centimeter. We are not disrupting much in the way of soft tissue or joints or tendons or anything like that. And so the postoperative pain is relatively mild. We do give mild pain medication postoperatively to help with that. But most of our patients are coming back within 1 to 2 days and saying, other than mild remaining pain, they're pretty much back to normal. Most people are going back to work either the following morning or the day after.
Thank you. Do patients go home the same day as the procedure?
Yes, actually, before I answer, I think the second part of the question was, do you need physical therapy afterwards? In general, the answer to that is no. As long as you are able to get out and exercise and walk on your own, which starts the following day. To answer this question, do patients go home the same day? Yes. In general, the procedure itself takes about 20 to 30 minutes to do, and patients are generally out of the hospital or procedure suite where we're doing it within 30 minutes after the procedure.
Thank you. Is there an upper or lower age limit?
There's no hard fast rule on age limits here. In general, we tend to do this in patients over the age of 50. We have made exceptions in the past, mainly because the younger patients tend to not have as much pain from arthritis. That's one of the reasons that we do the medial branch blocks, is to ensure that the procedure itself will work. Upper age limits, there really aren't many unless the patient has some issue with being able to undergo anesthesia or sedation of some sort. If you're comparing this procedure to something like an ablation or to a bigger spine surgery, it's much closer to the ablation and the bigger spine surgery. Again, it's a very small procedure. We are able to do this under sedation, so patients that are not eligible for complete anesthesia are still eligible for this procedure. And a lot of times, older patients may not be as physically fit and may not be able to undergo a larger spine surgery that would be required to fix everything they have. In those cases, we opt to do the ablation or the medial branch transection, as it's a much smaller procedure and easier to recover from.
Thank you. What other treatments do you try before trying a medial branch transection?
Yeah, I think we might have touched on this a little bit earlier, right? But to reiterate it again, so we generally start with physical therapy and oral medication. About 70% of people get better just by doing the physical therapy alone. If that does, and I should say that the studies show that takes about 6 to 8 weeks to work. So it's not like you go one time to therapy and it's over. This is something that you have to continually do for at least 6 to 8 weeks, but it does have good results. If those fail to work, that's when we talk about getting more advanced imaging, and we talk about doing slightly more invasive procedures, such as injections. The injections, again, will identify the exact problem and help guide us in the future treatments. So physical therapy, oral medication, injections, when all of those fail to work and you're in significant pain, that's when we would start to consider something like a medial branch transection.
Thank you. Is this done in the hospital or in an office? You mentioned a procedure suite and a hospital in your remarks.
So this is not an in-office procedure. This does require some kind of procedure or hospital-like setting. At the moment, we are doing all of them in the hospital. However, we do plan on moving them to other locations. The biggest holdup to that right now is having the equipment available. This obviously is very expensive equipment, and we have to, pick and choose where we're able to provide this type of treatment. But again, in the future, we do plan on doing this at outpatient surgery centers, hospitals, and maybe procedure suites, depending on what happens.
Thank you. Can you have this done if you have scoliosis?
You absolutely can have this done if you have scoliosis. That should really have no bearing on whether or not this is a valid procedure for you. I think there are other factors if you have scoliosis that may or may not make you eligible. In that case, I would recommend come in and see us so that we can get images, identify what the problem is, and talk about treatment options.
Thank you. We had several people asking if this helps if you have severe spinal stenosis.
That is a great question with a very difficult answer, I believe. Probably not an answer I'm going to be able to give you here in such a informal setting. If the question is, will doing a medial branch transection fix stenosis? The answer is no. I think the bigger question to ask is the stenosis causing your pain? And that is something that we would have to delve into one-on-one in an office setting. The answer is possibly, but without having a full exam, all the imaging available, the history, other treatment options that have been tried or we could try in the future, it's very difficult to answer that question. We've definitely had patients come in that did have severe stenosis, but the stenosis was not the main cause of the pain, and the medial branch transection has significantly improved their lives.
Thank you, Dr. McGowan. That is all the questions for today. Would you like to close?
Sure. Again, thank you everybody for joining us today. We really appreciate it. We just spoke about one topic today, medial branch transection. This is tip of the iceberg when it comes to endoscopic spine. We are really starting to do a lot more of this. We're beginning to do discectomies and fusions and all the stuff that we used to do big and open and maximally invasive. And we're now able to do it with an 8mm camera, get patients back to work and to life a lot quicker in a much safer way. So we are extremely excited about this technology, amongst other technologies that we've brought in over the past couple of years. We truly feel that here at OrthoVirginia, our spine program, as well as the rest of our group, is really on the cutting edge of technology, getting patients better, faster, and we are extremely excited for the future.